Welcome back to the deep dive. So today, let's just mark a very specific moment in time. I want you to mentally close the book on first aid.
hmm
You've memorized the Krebs cycle, you've regurgitated all the enzyme deficiencies, and you've successfully navigated USMLE Step 1. That part is over.
Which is a massive relief, but it's also the start of something, well, significantly more terrifying. You're trading Scantron sheets for actual human being.
Right, exactly. So you are walking onto the ward's third-year internal medicine clerkship, and you're about to meet Kevin.
And Kevin is your new reality.
And the reason we are obsessing over Kevin today isn't because his diagnosis is some kind of medical mystery spoiler, it's type 2 diabetes, but because the way you've been taught to think about it in the classroom is likely, 2 decades behind the clinical reality you're about to walk into.
It's a difference between memorizing a pathway and managing a collapse. In the textbook, diabetes is a chapter. In Kevin, it's a systemic metabolic failure that's currently dismantling his vascular system while he's sitting there talking to you.
So let's audit Kevin. He's a 52-year-old accountant. And I say audit because his body is essentially keeping a ledger of errors that have been compounding for years.
Yeah.
He presents with a 6-month decline.
And that time frame is, well, it's deceptive, right? Patients report the symptoms when they become intolerable, but the pathology, it doesn't really care about the calendar.
His chief complaints are the classics. He's drinking water like it's his job, and he's waking up 3, maybe 4 times a night to urinate. Now, we know the physiology here, osmotic diuresis. But let's get specific. Why now? Why did he cross that line 6 months ago?
It's all about the renal threshold. The kidneys are actually incredibly good at recycling glucose via the SGLT2 transporters. They reclaim everything up to a blood glucose of about 180 milligdl.
So he was probably fine for years before this.
Oh, absolutely. Kevin has likely been hovering in the 140s, maybe 150s for a long, long time, completely asymptomatic. But once he broke that 180 ceiling, the transporters just saturated. Glucose spilled, the water followed, and that whole cycle of dehydration began.
And that leads to the polydipsia, the constant thirst. But here's the detail in the chart that usually trips up students who are fresh off the boards. Kevin has gained 15 pounds in this same 6-month window.
Right.
In the Step 1 vignette, uncontrolled diabetes is usually catabolic. You see weight loss, muscle wasting.
That is the type 1 presentation, or maybe absolute end stage type 2. That's insulin deficiency. Kevin is swimming in insulin. He has type 2. He is hyperinsulinemic. And we have to remember, insulin is the ultimate anabolic storage hormone.
It locks fat into adipose tissue.
Right. It's a one-way street for fat storage.
So even though his cells are literally starving for glucose because of the resistance, his circulating insulin is aggressively storing every single calorie he consumes as fat.
Precisely. It's a metabolic paradox. He is gaining weight because of the insulin resistance, and that weight gain, specifically the visceral adiposity, is driving the resistance even further. It's a feedback loop from hell.
Wow. Okay, he also mentions intermittent blurry vision, and I'm assuming this isn't just him needing reading glasses for his spreadsheets.
No, not at all. This is osmotic flux in the lens of the eye. As his glucose levels swing, sorbitol accumulates, water gets pulled into the lens, and the shape actually changes. It's a fantastic real-time biomarker, actually.
Oh, interesting.
Yeah, if a patient ever tells you their vision changes day to day or even hour to hour, you know their glycemic variability is massive.
Okay, let's talk about the loaded gun. Kevin's family history is practically a prophecy. His father had a myocardial infarction at 60. His brother has type 2 diabetes. Kevin is 52.
So that leaves him, what, an 8-year runway before he hits the same wall his father did? And this is where you have to shift your thinking. We aren't just treating high sugar. We are interrupting a genetic legacy of vascular destruction.
Speaking of vascular destruction, let's look at the physical exam. His BP is 148/92. EMI is 34.1.
So he's effectively hypertensive and has class 1 obesity. And we need to be really rigorous with that staging. Class 1 obesity isn't just a cosmetic description, it's a pro-inflammatory state. Those adipocytes aren't just storage bags, they're endocrine organs pumping out cytokines.
And there's physical proof of that on his neck. The chart notes acanthosis nigricans.
The dirty neck.
But it's not dirt. And what's fascinating is the mechanism here. This isn't just, pigmentation.
Right. It's crossover signaling. Kevin's insulin levels are so astronomical that the insulin is spilling over and binding to IGF-1, that's insulin-like growth factor receptors on the keratinocytes and fibroblasts in his skin. It's driving cell proliferation.
So when you see that dark velvety patch on the back of his neck, you are essentially looking at a billboard for hyperinsulinemia.
Exactly. You don't need a lab test to know he has insulin resistance. His skin is shouting it. If we had just looked at his neck 5 years ago, we probably could have predicted this day.
Let's move to the labs, because this is where that metabolic cluster concept really solidifies. Fasting glucose is 162. A1C is 8.1%.
Yeah, we know that's diabetes. No debate on the cutoffs.
Right. But I want to look at the lipid panel. Triglycerides are 245. HDL is 34.
That's the classic diabetic dyslipidemia. It's characteristic.
Why that specific pattern, though? Why does insulin resistance just hammer the HDL?
It's all about clearance. In a healthy state, insulin helps regulate the enzyme lipoprotein lipase, which clears triglycerides from the blood. When you're resistant, that clearance just drops. Your VLDL shoots up.
Okay.
And through a process involving CETP, that excess triglyceride gets swapped into your HDL particles, making them unstable and easily cleared by the kidney. So you end up with high trigs, and your good cholesterol just gets flushed out.
So his lipid profile is essentially promoting plaque formation every minute of every day.
Okay.
But the lab result that actually scared me, the one that changes Kevin's case from manageable to urgent, is the urine.
The microalbumin.
45 milligrams per gram.
This is the pivotal data point. A standard of BMP would show his creatinine is normal. You might look at that and think, his kidneys are fine.
They are not.
They are not. That 45 means the glomerular filtration barrier is already compromised. He is leaking protein.
So the vascular damage isn't some theoretical thing that might happen in the future. It's happening right now.
It is underway. This is stage A1 or A2 diabetic nephropathy. The clock isn't ticking anymore. The alarm is ringing. We are now in damage control.
This brings us to the so what? We've established he's a metabolic mess. He's got the sugar, the pressure, the lipids, and the leaky kidneys. We need to build a regimen. And this is where the guidelines have just completely exploded in the last few years.
Oh, yeah.
10 years ago, you would have just given him metformin and told him to eat a salad.
And we would have failed him. Completely.
So let's break down the modern approach.
Yeah.
We assume metformin is on board. It's still the foundation, right?
It is, absolutely. Unless his eGFR is totally tanked, which it isn't yet, metformin's the anchor. It targets the liver, shutting down that inappropriate gluconeogenesis. It's cheap, it's effective, and we know the long-term safety profile.
Okay, so he's taking 500 milligrams with dinner, titrating up slowly to avoid the GI side effects.
Yeah.
But metformin alone isn't going to fix the microalbuminuria or the heart risk. This is where we get into the heavy artillery. We have to choose a second agent. And this is a real debate. Do we go GLP-1 agonist or an SGLT2 inhibitor? Or both?
This is the critical clinical decision node. The guidelines now say you choose the drug based on the comorbidity, not just the A1C. We're treating the organs, not the number.
Let's make the case for the GLP-1, the semaglutide or tirzepatide route.
Yeah.
Kevin has class 1 obesity.
Right. And the GLP-1 agonists are potent because they fix that incretin defect. They restore the gut-pancreas signaling. But for Kevin, the biggest value add here is, well, it's the weight loss and atherosclerosis protection. The LEADER trial and others showed a significant reduction in MACE major adverse cardiovascular events.
So if we're trying to prevent his father's heart attack.
A GLP-1 is a very strong contender. It attacks the root cause, the adiposity.
However, Kevin's an accountant. He sits all day. He's stressed. Injectables can be a hurdle, even though the weekly dosing helps now.
Yeah.
But look at that microalbumin again, 45 milligrams. Does that push you toward the other class, the SGLT2 inhibitors?
It really does. I mean, the SGLT2s, empagliflozin, tepagliflozin, and they are the kidney guardians.
Mechanistically, how? We know they make you pee out sugar. How does that save a kidney that's already leaking?
It's all about hemodynamics. In diabetes, the afferent arteriole, which is the blood vessel entering the kidney filter, is dilated, so you have high pressure. SGLT2 inhibitors trigger a feedback loop that constricts that arteriole, which reduces the intraglomerular pressure.
It's like turning down the fire hose so you don't blow out the filter.
That's a perfect analogy. You are physically depressurizing the kidney. And the data from trials like MPAR-RED is just undeniable for heart failure and renal protection. Given that Kevin already has albuminuria, an SGLT2 inhibitor is almost mandatory to stop that progression to dialysis 10 years from now.
So here's the conflict. The GLP-1 is better for his waistline and his arteries. The SGLT2 is better for his kidneys and his volume status. What do we do?
The by-the-book answer, he probably needs both. The real-world answer, you have to consider pill burden, cost, all of it.
So what's your first move?
If I'm sitting there with Kevin, I'm looking at that microalbumin, I might lean towards starting the SGLT2 inhibitor immediately alongside the metformin because the kidney damage is active now. Plus, it's an oral pill. That might be an easier sell for our stressed out accountant than a needle.
But we can't ignore the weight.
No, absolutely not. So the
Oh.
plan is likely start metformin and the SGLT2 now, reassess in 3 months. If the weight hasn't budged, if the A1C is still high, then we add the GLP-1. We have to be aggressive. We're treating a cluster, not a number.
And speaking of the cluster, we're not done writing prescriptions. We've addressed the sugar in the kidneys. What about the pressure? He's a 148/92.
You cannot let him leave without an ACE inhibitor or an ARB, lisinopril or losartan, period.
And this isn't just for blood pressure. This ties back to the kidney.
Exactly. It's the same mechanism, just from the other side. ACEs and ARBs dilate the errant arteriole, the exit pipe. So combined with the SGLT2, you are maximally depressurizing that kidney filter. It is the standard of care for albuminuria.
And finally, the statins. Even if his LDL wasn't terrible, which, let's be honest, it probably is given the high trigs, he needs a high-intensity statin.
Absolutely. At 52 with diabetes and hypertension, his ASCVD risk score is flashing bright red. We need to stabilize those plaques.
So let's just pause and look at this from Kevin's perspective. He walked in feeling a little off. He's walking out with a diagnosis of a chronic systemic disease and 4 prescriptions: metformin, an SGLT2, lisinopril, and atorvastatin. I mean, that is a massive psychological load.
It is, and that's why the soft skills of the third year are just as hard as the pharmacology. If you just hand him the scripts and say, good luck, he won't take them. You have to explain the strategy. Kevin, this pill protects your kidneys. This one protects your heart. This one helps your liver. You have to sell the protection, not just the correction.
And we haven't even touched on the hardest part for an accountant: lifestyle. Eat better and exercise is just the most useless advice in medicine because it's not actionable.
It's noise. It's just noise. For Kevin, we need an audit of his habits. The low-hanging fruit, he's drinking sugary soda, that's gone. That is non-negotiable. That liquid sugar spikes blood glucose faster than almost anything else.
And the sedentary job.
Yeah, he's sedentary. We don't need him training for a marathon. We need movement snacks. Stand up every hour. Walk for 15 minutes after lunch.
Using his muscles as a glucose sink.
Exactly. Muscle contraction moves glucose into cells independent of insulin. It's a back door. If he walks after a meal, he can literally flatten that glucose curve without needing more drugs.
So bringing this all back to the learner who is standing there in the room with Kevin. You've done the history, you've seen the dirty neck, you've interpreted the terrifying microalbumin number, and you've mentally formulated this 4-drug cocktail. What's the prognosis? Is Kevin on a one-way track to his father's heart attack?
No. And that is the important part. This is reversible, or at least haltingly manageable. If he loses 10 to 15% of his body weight, which the SGLT2 and a future GLP-1 will help with, and if he adheres to the statin and the ACE, his risk profile will drop dramatically. The body is forgiving, but only to a point.
But we have to catch it now.
We have to catch it now.
Yeah.
We can't wait for the A1C to hit 10%.
So what's the pearl? If you, the student, take one thing from this deep dive into Kevin's chart, what is it?
The pearl is, don't treat the glucose, treat the risk. If you high-five yourself for getting his sugar to 100, but you ignore his blood pressure and the albuminuria, Kevin still dies of heart failure or kidney disease. You have to treat the metabolic syndrome as a single, multi-headed monster. You are a risk manager, not a sugar monitor.
And I want to leave everyone with a thought about that 6-month timeline Kevin gave us. We know pathology doesn't happen overnight. The beta cell failure, the insulin resistance, the sheer stress on the vessels, that all started years ago. So if we as a system were better at spotting the acanthasis nigricans, that dark patch on the neck, 5 years ago when his labs were technically normal, could we have prevented all the polypharmacy we're doing today?
The skin usually tells us what the pancreas is hiding long before the labs turn red.
A sobering thought for your next physical exam. Check the neck. Thanks for diving in with us. Good luck on the wards.
Keep learning.